today, because I think it's definitely a hot topic and one that we find very fascinating. We will be releasing a module from this presentation. So Tim, do you have a timeline on when you think this will be out and ready for view?
Yeah, we should be releasing the module within the next couple of weeks. So I'll send out an email to everyone to let everyone know. It will be a standalone, and then for those of you who are already enrolled in the Cannabis for Healthcare Professionals, recall that we're no longer selling that new, but we'll be adding the content into that also. So that if you're still within your 1-year term, we want to make sure that you're still getting new content as well.
Awesome. Okie dokie. Adam, you're not on mute. Do you mind if I mute you? There's a little buzz. There you go. Thank you. Okay. Great. Okay, so cannabinoid hyperemesis syndrome, also known as CHS. It's a rare side effect of long-term chronic cannabis use, typically characterized by cyclic and intractable nausea and vomiting, abdominal pain, and compulsive and hot water bathing. Adam, I'm going to have to mute you. I'm sorry. There we go. Symptoms of cannabinoid hyperemesis syndrome. We know nausea, tendency to use extremely hot baths, showers for relief, stomach pain, difficulty eating or keeping food down, weight loss, severe vomiting and or diarrhea, sometimes for days or weeks. We know that Adam, you keep coming off mute.
It says I'm muted.
You're not. You are muted and then it goes off mute for some reason. Maybe the powers to be really think you have something you need to say. Okay. The first cannabinoid hyperemesis patients were diagnosed in Australia in 2004. 9 patients were diagnosed with the disorder, and shortly after, another 22 cases were reported in Canada, Great Britain, Spain, the Netherlands, New Zealand, and the United States. Subsequent cases that describe similar presentations and positive responses to cannabis abstinence have been published worldwide in the medical literature. Sometimes estimates include over 200 cases of CHS that have now been identified. I believe that the incidence rate is about 0.77%. So I can tell you that in the 6,000 patients I've worked with, I've seen this twice. And I am going to present one of the cases today as part of this webinar. And Dr. Zulak and I did do a submission in the American Endocannabinoid Journal of Medicine with our atypical cannabinoid hyperemesis cases. So the risk of developing CHS really depends on a multitude of factors, and many of those are speculative, which includes the amount of cannabis the patient uses, confounding medical, psychiatric, and socioeconomic conditions. But because of the rarity of the condition, patients can go undiagnosed with debilitating symptoms and often receive multiple diagnostic tests that are invasive, expensive, and they end up with no proper diagnosis. And this often happens a lot in the emergency room, because by the time, we'll talk about the different stages, but as the patients get to the hyperemesis state, they're often so sick that they end up in the emergency room, and it does get misdiagnosed. The cannabis industry.
I just want to add that, when we talk about compulsive hot water bathing, when you look at the literature, these are people who are bathing for 3 hours at a time. We're taking 4 or 5 hot showers a day. So this isn't taking a long 20-minute shower, but rather it really is compulsive behavior.
Okay, that's really important to differentiate as well. Thank you, Tim. Because right now I think bathing and showering in our house has become both a sport and a hobby, but it's not compulsive yet. So, the cannabis industry is actually quite skeptical of cannabinoid hyperemesis, and they often dismiss it. There is an advocate, Alice Moon, in the industry who developed cannabinoid hyperemesis and has been very outspoken trying to educate the community and clinicians on this diagnosis. And she has received quite a bit of pushback and even some hate messages from people in the industry. And in 2013, Paul Armentano, the deputy director of the National Organization for the Reform of Marijuana Laws, also known as NORML, stated that such a phenomenon, when documented, is so rare to be, from a practical standpoint, irrelevant. I would disagree with that statement. I think we definitely need to be aware of this as clinicians and people in the industry so that we can properly diagnose it. There have been some cases that the cannabinoid hyperemesis has become so severe that people have died from dehydration and kidney failure.
Eloise, just to let you know, the slides are not advancing.
Oh, what slide do you see?
The first one. And it's not actually not in the presentation mode.
Oh, it's not? Okay.
And just to be fair to Paul, it was a quote from 2013. So this was, you know, several years ago. I think we understand CHS a little bit better than we did back then. But I think at the time it probably felt like, you know, this was another case where, you know, everyone just points at the cannabis and says, oh, it's the cannabis's fault. And so I think that's the knee-jerk reaction that the industry had.
Yes, and you know, I respect Paul very much, and I would be curious to get an updated statement from him at this point to see how he feels about it now. So I'm having some technical issues here now. I apologize to the two people that are here. Hang in there with us.
You want me to try to share it from my end?
Sure. There's a way in Zoom that you're supposed to be able to have a smaller window, you know, so that I can have a screen up if I want to of other things. But I don't know why that's not working.
Can you guys see my screen now?
I can, yeah.
Okay. So symptoms. So these are the symptoms that we talked about. First case is diagnosed in Australia, 2004. And then this slide was about the patients are underdiagnosed or misdiagnosed, receive invasive procedures.
Okay, next slide.
And caught up.
Okay. So there are a lot of critics, like we said, around cannabinoid hyperemesis. And in addition to Paul Armentano's statement, there's also Russ Hudson. He's a cannabis consultant based in Barcelona. And he stated in an interview through Leafly that he believes that most of us that are veterans in the cannabis industry, people with 20 plus years of experience, think that cannabinoid hyperemesis is made up or a severely misunderstood condition. I would agree with the latter part. I think it's severely misunderstood. You know, those who suffer from it will tell you it's not made up, but because it's misunderstood, it's poorly diagnosed, it's usually often underdiagnosed. So we really need to bring attention to this so that we can help facilitate faster diagnoses and decrease the costs associated with unnecessary testing and emergency room visits. And there have been increased reports of CHS in states that have legalized cannabis, particularly usually you see this diagnosis in young men in their 20s, and they're definitely seeing an increase in incidence among that population in states like Washington and Colorado, where they end up in the emergency room. So one of the early speculations around CHS and its etiology was related to pesticide poisoning. And I guess, again, Russ Hudson had suggested that the severe nausea and vomiting associated with CHS was likely due to pesticide poisoning, specifically neem oil, which contains azadirachtin. Hopefully I said that right. Adam, tell me if I didn't. Which is known to be toxic in large doses and can cause the nausea and vomiting. Will you do next slide, please? However, Dr. Ethan Russo disagrees, and he said that as much as I decry the use of pesticides on cannabis, their toxicity profile does not match the symptom complex or time course of CHS. Neem oil and azadirachtin generally have limited human toxicity, but can rarely produce vomiting, the only symptom in common with CHS. This is someone's wishful thinking. And he also went on to state that overdose with azadirachtin also includes increased salivation, diarrhea, liver toxicity, and convulsions, which we rarely see in CHS. You may see diarrhea. And also, these symptoms are with neem oil poisoning are not going to be alleviated by the compulsive hot water bathing. So if it's not pesticides, then what do we think may be causing these symptoms? Well, we know that the antiemetic effects of THC are likely being mediated by the CB1 stimulation in the brainstem. And we can recall that cannabis is biphasic. We know that low doses of cannabinoids can produce effects that are very different than these high doses of the same cannabinoid. So for example, at low doses, THC can be an effective antiemetic and can reduce nausea. But can very high doses or chronic long-term use of THC cause the nausea and vomiting? I can share with you a case that happened many years ago, early on when I was working with patients. I had a 70-something-year-old gentleman with lung cancer who wanted to use THC as a potential treatment for his lung cancer. Even though there's no clinical trials to support THC's ability to cure cancer, especially lung cancer, there have been some animal studies to show that THC can actually kill lung cancer cells. So he wanted to try cannabis, and we worked up towards a dose of 450 milligrams of THC daily, and it took him many months to get to that dose. And his daughter, who was a nurse, decided one day on her own to try her father's dose of 450 milligrams to see what he was experiencing. And she was cannabis naive. She had no previous cannabis experience. And when she took that 450 milligram dose, she ended up in bed and had been vomiting pretty much nonstop for about a week, she had reported. And, you know, luckily she recovered well from it and didn't have any permanent negative effects, but it went to kind of show that extreme biphasic effect of a large dose. Clearly her body seemed to be rejecting it, and that was why she had such severe nausea and vomiting for that week. And there also exists at least one case of a patient developing a condition diagnosed as CHS after chronic use of synthetic cannabinoids. Even though his urine test was negative for delta-9 THC, but he ended up admitting that he was using K2 and kryptonite, products that he had purchased from an illicit market, which typically contains synthetic cannabinoids. Synthetic cannabinoids are full agonists and have a high affinity at the CB1 receptor. So it's possible that severe downregulation of CB1 receptors, creating high tolerances after long-term and chronic use, might be responsible for hyperemesis. Thanks, Tim. We also have some speculation that CHS does not arise solely from dysregulation of CB1 signaling. For example, the compulsive hot water bathing symptom has led some clinicians to suspect that involvement of our transient receptor potential vilanoid subtype, also known as TRPV1 receptor, which is activated by cannabis as well as capsaicin and heat. Chronic cannabis use decreases our TRPV1 signaling and alters our gastric motility. And in one case, a CHS patient experienced complete resolution of abdominal pain and nausea by simply applying a topical capsaicin treatment cream to the abdomen. Now, I think we're a little bit skeptical of that working because TRPV receptors are highly expressed in the gastrointestinal tract, but also in the central nervous system. In fact, the highest density of these receptors is in our brainstem, specifically the area post-strema, the part of the brainstem that initiates vomiting. And TRPV receptors mediate pain and temperature sensation, and TRPV activation can produce potent anti-emetic effects. But TRPV receptors are activated by temperatures greater than 109 degrees, by acidic conditions, by capsaicin, the molecule that makes chili taste spicy, and by allyl isothiocyanate, which is a pungent compound in mustard and wasabi. The activation of TRPV1 produces a painful and burning sensation. So CBD, CBG, CBGV, and THCV are all TRPV1 agonists. TRPV1 agonists, however, after prolonged exposure can downregulate and inactivate receptors via desensitization, which might cause nausea, altered gastric motility, and abdominal pain. Exposure to heat, such as with compulsive hot water bathing, might augment cutaneous TRPV activation, restore gastric motility, and mitigate other CHS symptoms. Capsaicin, another TRPV1 agonist, might also provide relief via similar mechanisms. However, has anybody, Adam or Tess, noticed one issue with TRPV1 regulation theory? The answer is right here. You see it? Oh, Adam, you can go ahead if you want to.
Oh, no, I was just saying I'm off the back. I'm trying to do 15 things at once. So,
so THC doesn't seem to have much affinity at TRPV1. It's most potent at our TRPV2 and moderately modulates TRPV3, TRPV4, TRPA1, and TRPM8. Consequently, it seems unlikely that CHS symptoms would be initiated by the desensitization of TRPV1 receptors. Though, for example, chronic and persistent use of THCV, CBGV, CBG, or even CBD may be based solely on the rarity of these compounds, especially in markets where there is no legal access. It might help explain, however, the use of even non-impairing cannabinoids can re-trigger CHS symptoms after the cessation of THC use. It might also help explain the symptoms relieved by hot water bathing.
Does that make sense to people? Can everyone understand how, because TRPV1 downregulation is only one of 3 proposed hypotheses for cannabinoid hyperemesis. And essentially what they're saying is, you know, these receptors are being activated to such an extent that they're being desensitized. So people are pounding on these receptors with cannabinoids until they're desensitized and they're not working any longer. But the only thing that activates them and can desensitize them are these rare cannabinoids that, you know, until recently people didn't even have access to. So these cases of CHS in the general public, especially older ones, it doesn't make much sense that this is a condition that would be initiated or caused by the use of these uncommon cannabinoids, CBD to some extent historically, but CBG, CBGV, THCV, these are just not cannabinoids that are available to people. And it seems really unlikely that people would be using them so much that they would desensitize the receptor.
can I ask a question?
Sure.
Always.
So the TRPV1 and THC interaction is mostly done in vitro or in vivo. Are we actually tracking TRPV1 stimulation like in the body after THC?
Yeah, there's very little affinity of THC at the TRPV1 receptors, if at all.
Yeah, and then so my question is like there's a potential for a downstream reaction happening that's actually has a higher affinity for TRPV1 after, you know, consuming THC, as opposed to THC plugging in directly. You know.
So are you asking if there are other mechanisms whereby THC might be influencing TRPV receptors?
Exactly.
None that I've heard about. You know, it's always possible. We know that cannabinoids, they're polyamorous, so they're binding with lots of different receptors. They're impacting different enzymes. So I think it's always possible that there could be a connection. I think that the fact that compulsive hot water bathing is a symptom implicates TRPV1, but I don't know that it's because of THC. But it could be, you know, that could be the missing link, perhaps, of how these things all tie together, because it doesn't. If you look at the medical literature and the people who are coming down with it and the different types of symptoms that they have and the different ways that they achieve relief, and then also the different ways that they go, that sometimes the condition is reactivated, there isn't a whole lot of, there are similarities, but there are also a lot of, quote unquote, atypical cases. So it could be, but I haven't seen anything in the literature.
Me either. And I think you bring up a really good point, Adam. I think most of the studies, well, as far as I know, all of the studies have been done, you know, in vitro and in vivo. And so maybe there is a difference in how cannabinoids are behaving in humans with these receptors that we haven't fully understood. And that's why this condition is so difficult to fully understand at this point. You want to do next slide, Tim? Please. So most likely there exists some combination of factors that are contributing to CHS. How do we account, though, for patients with cannabinoid-induced gastrointestinal issues that do not clearly fit the expected presentation of CHS? So, for example, in some documented cases, hot bathing did not relieve symptoms, and complete abstinence of cannabis was not required to prevent symptoms. In other cases, cannabinoids with no or little affinity with CB1 receptors seem to be responsible for triggering these gastrointestinal symptoms. And conditions such as acute infections and chronic gastrointestinal conditions might complicate the presentation of cannabinoid-induced GI symptoms. In fact, multiple etiology theories for CHS involve several contributing factors have been proposed. For example, enzyme polymorphisms that create excessive levels of cannabis metabolites might promote CHS. Patients with chemical sensitivities might experience TH toxicity and subsequent nausea and vomiting when THC accumulates in cerebral fat. And other theories suggest that cannabis toxicity can delay gastric emptying and disrupt the equilibrium of satiety, thirst, digestion, and thermoregulatory systems in the hypothalamus. Next slide, please. And patients might experience GI issues from exposures to pesticides or other toxic materials. Products might contain very high concentrations of magnesium, which can produce diarrhea, nausea, and abdominal cramping. So this is an area where, you know, I started to get a little bit more curious about what could be contributing to some of these symptoms. You know, patients may be experiencing these GI symptoms from exposure to pesticides from the long, you know, even though they may be in low amounts from long-term or chronic exposure. But we're just now starting to test some of our hemp products for minerals. And some of them are coming back with very high concentrations of magnesium, phosphorus, potassium. We know that concentrations that exceed 5,000 milligrams of magnesium have been associated with magnesium toxicity, and that can produce symptoms like diarrhea, nausea, and abdominal cramping. And if, you know, left undiagnosed and untreated, it can also end up leading to hypotension, nausea, vomiting, facial flushing, retention of urine, ileus, depression, lethargy, and can progress to muscle weakness, difficulty breathing, irregular heartbeat, and even cardiac arrest. While testing for heavy metals is well established in the cannabis and hemp industry, testing for minerals is really in its infancy, and historically minerals have not been identified as possible toxins, nor have we established safety standards yet within these products. Next slide, please.
Can I ask a quick question about the minerals?
Sure.
Sorry. Do we know what happens through pyrolysis with things like magnesium? Like, can you actually, will it vaporize and go and be absorbed through the lungs?
That's a really good question. I don't know. You know, I started to kind of dig into more of what happens when we're ingesting these products that have tested for high levels. And there's really not much out there. Tim, do you come across
No, that's a great question. And I wonder, so it's got me wondering now, like how is the magnesium, for example, or these, how are they introduced? Are they introduced via, you know, is it in the like the soil that they're producing to help with the to help the plants grow better? Is it a pesticide that they're using? Do we know how it's introduced?
I think through feeding of, Adam, you and I had some discussion on this. I'd love to hear your comments.
Yeah, so I mean, there's two ways to introduce it to the plant, like in the basic, you know, uptake is, you know, either through the roots or through the leaves. So there's a lot of foliar feeding to address deficiencies currently. There's definitely overuse of calcium magnesium products. It's really important with cannabis to have about a 5-to-1 or 7-to-1 ratio of calcium to magnesium. So, you know, people are introducing those calcium magnesium specific products both through the roots and through the leaves through foliar feeding. So, you know, there's also the difference between a, you know, chemically chelated product and a microbially digested product, right? That's getting into the plant through natural soil microbe digestion versus adding a chemical salt that's, you know, mined and moved and then introduced to the plant.
And Eloise, in your case study, she was consuming cannabis orally, correct?
Through tincture form. I believe in Dr. Sulak's case study, it was through inhalation.
Interesting.
Yeah.
And the fact that tincture, if it's an alcohol tincture, it's, you know, a polar solvent, so it can really only pull out certain things. I'd be super interested as to like what kind of minerals it's pulling out.
Yeah, I think it's an area where we need to start doing more due diligence around testing and identifying these these potential factors.
Exactly.
Yeah, it's exciting and also, you know, challenging because we just don't know what we don't know. Yeah, so with right now with CHS, there's three different stages that have been identified. There's the prodromal phase, the hyperemetic phase, and the recovery phase. Within the prodromal phase, it can extend for months or years. It's characterized by the development of morning nausea, the fear of vomiting, abdominal cramping or discomfort. Symptoms seem to appear early in middle-aged adults who have consistently used cannabis since adolescence. And there is no or little evidence of compulsive bathing during this phase, and normal eating patterns might remain intact. So some patients may increase the use of cannabis during their prodromal phase to address their increased nausea and vomiting. And in my case study, you'll see me talk about whether or not she was an atypical case or did I catch her in the prodromal phase? Next slide, Tim. The hyperemetic phase is characterized by frequent abdominal pain that's persistent and incapacitating with nausea and vomiting and retching. And patients typically decrease their oral intake. Some develop conditioned food aversion, and they subsequently experience weight loss and dehydration. This phase is also where you may see the compulsive hot water bathing, where patients discover that the hot water bathing, and as Tim mentioned earlier, it is temperature specific. 109 degrees is usually, I mean, it has to be hot. It becomes compulsive, with some patients reporting multiple bathing throughout the day or single bathing episodes lasting for several hours. The symptomatic relief is temperature dependent. The hotter the water, the more relief is experienced. Symptom relief via compulsive hot water bathing seems to further implicate the dysregulation at the CB1 receptor. There exists enough evidence to suggest that the ECS, and specifically CB1, modulates the regulation of body temperature. Certainly, it's been established that rodents treated with cannabinoids commonly exhibit hypothermia. It should also be noted that hypothermia is observed only when these animals were administered high doses of delta-9 THC. In fact, we've seen the same hypothermic symptoms in people using the illicit markets, products, the K2 or spice, that are sprayed with synthetic cannabinoids like HU210 and JWH018. Those are full agonists with high affinity at our CB1 receptors. So during the hyperemetic phase, patients are often brought to the emergency departments to seek help, where they can undergo extensive diagnostic workups at a great cost to the patient and our healthcare system.
So just to clarify, because I know we've been talking about TRPV1 and hot water and compulsive hot water bathing, you can see how CB1 dysregulation might also be implicated here, because we know that high doses and chronic doses of THC can lower our body temperature, and so maybe it's just people are cold, and so they get into a hot shower and it brings them relief. Or maybe it's, if they can get that hot shower hot enough to actually start activating the TRPV1 receptors, they've been desensitized theoretically by cannabinoids. The hot water reactivates them and provides some relief.
Thanks, Tim. And the recovery phase is characterized by cannabis cessation. So usually they have to stop to be able to return to a relative state of wellness. And they often will report that any use of cannabis, whether it's CBD or CBG, will cause a recurrence of their CHS symptoms. And I'm going to talk about that in my case study. But next, we're going to talk a little bit about diagnostic criteria. So clinical guidelines to diagnose CHS still do not exist. There's a consensus around the following, and I don't know that this consensus has been reviewed by cannabis clinicians. So at this point right now, long-term and chronic cannabis use, usually lasting more than a year, severe and recurring nausea and vomiting, symptom relief with hot showers or baths, abdominal pain, and symptoms that resolve after stopping cannabis use. My concerns about this, this criteria is that, again, many patients may be in that prodromal phase and not at the point where they're doing the compulsive hot bathing or showering, and they may be misdiagnosed. Next slide. Some of the other criteria that support a diagnosis of CHS, our patients are often younger than 50 years old, but not always. They've experienced weight loss for more than 10 pounds. They have experienced morning nausea and vomiting, and they may have normal bowel habits, but not always. They may also have diarrhea. So in terms of treatment, again, there's no standard treatment guidelines for the management of CHS. What's really important is that we are trying to consider, an atypical diagnosis, and then advising patients to, in my case study, when I was suspecting CHS, I asked this patient to come off cannabis. And because she'd been using it for quite a while, the goal was to have her wean off the cannabis to avoid withdrawal, because sometimes abrupt cessation of cannabinoid use can lead to withdrawals. So people can actually have nausea, diarrhea, restlessness, irritability, headaches, and insomnia. So to help avoid complicating things or giving them more symptoms, weaning them is usually the best way to avoid that. Addressing their hydration, providing intravenous solutions if they cannot tolerate oral fluids, addressing their addressing their nausea and vomiting. And this is challenging because many of the anti-nausea medications are ineffective. So our standards of care usually don't fix the problem. There has been a couple of case reports where they have found Haldol, which is actually an antipsychotic, to be effective at treating the nausea and vomiting of CHS. And we've used Haldol off-label for nausea and vomiting in some of our end-of-life patients in hospice and palliative care. And often people will also offer pain relievers if abdominal pain is present. Next slide, please. So this is an algorithm that was developed, you know, in the review of the current medical literature. And, you know, I think what Tim and I are going to work on is developing a different algorithm that really is coming from the perspective of cannabis clinicians who are working with these patients. Because remember, we have these 3 different stages. And when I look at this algorithm, my concern is that, you know, the first thing it says is if a patient presents with nausea and vomiting, you know, signs and symptoms suggest severe underlying medical cause. Well, you know, if the patient is not, you know, taking hot showers or baths to improve their symptoms, they automatically get excluded for CHS according to this algorithm, right? So again, they may be in that prodromal phase, and we don't want to exclude potential diagnosis of CHS if we know that they're a cannabis user. But I think the other challenge that we have of really diagnosing this in patients is because of over the years, the stigma and the prohibition of cannabis has led many people to be less than upfront about their cannabis use. You know, they're a little bit afraid to disclose how much they're using, how often they're using it, or where they're even getting it. So again, it makes it difficult for clinicians to be able to diagnose this because they may not be getting all the information they need from their patient for a multitude of factors, right? We know with cannabis, nothing is easy because of the stigma and the prohibition over the years. So it's another example of if a patient came into the emergency room, may not be completely transparent and upfront about their use.
Sorry, Eloise, I just realized I had the wrong slide deck up.
Oh, okay, no problem. Wait for it.
Here it comes.
Wait for it. Okay. So this is the case study I wanted to present. And again, is it an atypical CHS or was she in the prodromal phase? So she doesn't fit some of the criteria that has been identified in the literature. She is a 66-year-old female. She has a history of diverse pain from fibromyalgia, also a history of chronic Lyme disease, migraines, and hypothyroidism. And she'd been using cannabis for about 2 years. It was a 1-to-1 CBD to THC tincture, oil-based, using about 1,500 to 2,000 milligrams a month, and which averaged out to about 50 to 75 milligrams of CBD and THC combined daily. In the last 2 months, she started to report nausea, loss of appetite, weight loss of 10 pounds, and diarrhea. She had complete workup, GI workup around this, and they could not identify any source. Next slide. So I started to suspect CHS in this patient. And during our health history review, I told her what I was suspecting, and she also admitted that she was wondering if the cannabis was causing her symptoms. And she said that she had stopped the cannabis for a week to see if cannabis was contributing to it. And during that time that she stopped, she said her symptoms did not change. I did ask her about whether or not she experienced any sort of withdrawals during that time when she stopped abruptly, and she said no. So I asked her if she'd be willing to stop the cannabis for 3 weeks to determine whether or not, and try to get it completely out of her system and see if her symptoms resolved. She was willing to stop for 3 weeks. and take her tramadol for pain. Again, I did not wean her off because she had no previous issues with withdrawals. And she actually did quite well coming off the cannabis. Her symptoms started to go away about 3 days before the end of that 3-week trial. You know, she reported that her symptoms had almost entirely resolved. There was only mild nausea after her 3rd meal of the day, and she was able to stop using her Zofran for nausea. Next slide. So she was really determined not to have to rely on any sort of pharmaceuticals for her pain. So after her symptoms had resolved, she wanted to restart the cannabis protocol to help treat her pain. I told her I was quite skeptical in terms of her restarting cannabis, and I was concerned that her symptoms would likely resume. And she said that she still wanted to try it. So we did start the 1-to-1 tincture actually. And within like 2 days, her symptoms came back with a vengeance. So after she reported that, I decided to try a high CBD to THC tincture, a 25-to-1 in olive oil. And I've been able to review the certificate of analysis on her 1-to-1 as well as the 25-to-1. So there was no evidence of pesticides, any heavy metals, bacteria, mold, or residual solvents. They did not test for minerals, so I'm not sure whether or not there was any you know, excessive levels of magnesium, phosphorus, or potassium. So I had her start with 12.5 milligrams of CBD twice a day, and after 5 days, her symptoms had returned. I had her stop the tincture, and her symptoms went away within 24 hours. So she still wanted to keep going. So at this point, I thought, well, let's try a CBG tincture. It had 21 milligrams of CBG per milliliter and only 0.22 milligrams of THC per milliliter to address her pain. And I started her out at about 10 milligrams per dose twice a day. Actually, what had happened here is I didn't hear from her for 3 weeks. So I had reached out to her to check in to see if her symptoms had returned. And during that 3 weeks, I hadn't heard from her. So I made an assumption that she was tolerating the CBG. She finally got back to me and told me that actually after 3 or 4 days, her symptoms did return and she had stopped the CBG, but hadn't reached out to me because she was in the process of moving. So what we decided to do at that point was I asked her if she would be willing to try a CBD isolate. I really wanted to see at this point, is THC the common denominator? Because so far, at whatever level, THC was involved in all of her different tinctures. And if we could find a CBD isolate that had test results to show no THC, would she still have these same symptoms? So she was reluctant to try that because she had not received any, even though she took the CBD and it gave her symptoms, she didn't get any pain relief from it. So she's, she really, I kind of gave her a talk of, I don't know that cannabis is the right thing for you anymore. I'm very concerned that anything that we try is just going to cause a resurgence of your gastrointestinal issues. And you may want to consider, other treatments for your pain. And she was very adamant that cannabis was something she really wanted to give another try. During that time, she had gone in to see her primary care physician, and her primary care physician was reviewing her supplements with her and identified that she was taking magnesium supplements and thought that maybe some of her GI issues could be related to magnesium toxicity, and pulled her off of her magnesium supplements. We decided to reintroduce the 1-to-1 tincture, which at that point, she was able to get pain relief again and actually has not had any resurgence of her symptoms since coming off the magnesium, which is where some of the theory lies right now in terms of, the mineral levels in some of our cannabinoid products, whether they're coming from hemp or cannabis. Is that contributing to some of these gastrointestinal issues that we see in chronic long-term cannabis users? Next slide. So at this point, our recommendations, if you're working with a patient and you suspect cannabinoid hyperemesis syndrome, is really to perform an in-depth analysis on their use. What route of administration, getting the profile on all of their products, the frequency, the amount per day, how long they've been using it, reviewing those certificates of analysis. Are there residual levels of hydrocarbons, pesticides, minerals, or other toxins present? Remember, it's not best practice yet for them to be testing for minerals. So some labs are, but most are not. And, does stopping the cannabis resolve symptoms? And how long did it take? And do their symptoms return when patients return to cannabis use? That's our current recommendations, but hopefully we'll start to see more consensus around diagnostic criteria and treatment for this very unusual condition associated with chronic cannabis use. All right, do you guys have questions or thoughts or feedback?
Yeah. Hi, Eloise. It's Tess.
Hi, Tess.
Obviously, the only other female there.
Nope, Ruth joined us.
Oh, hi. I think that's real interesting about the magnesium. And the other part about it is, people who were in their 50s and 60s and they've been using cannabis for so long that they've just been getting street cannabis, from their local dealer. So there's really a hard way to track what they've actually been ingesting. I have a friend, Aaron. He's now 30, he'll be 36, and about 6 years ago, he came to stay with me, and he was doing the hot showers. Mm-hmm. He also has a dual diagnosis, manic depressive and drug abuse. But what he would do is he would take the shower, but he would bang on the side of the shower around his kidney area. And I think that maybe because, maybe he was really getting dehydrated. But that was one of the first, actually his brother had told him that's probably what it is. But and he'd be going to his mother would just eventually just drive up to the emergency room and just drop him off because he'd been going so many different times to the emergency room. Wow. But he was also getting narcotics then for the pain. So it was getting kind of complicated. But to make a long story short, now he's diagnosed with lupus.
With lupus?
Yes, lupus.
Interesting. Is he still cannabis then? Yeah,
he does. He'll do cannabis, not a lot.
Uh-huh. And is he still taking hot showers or any compulsive bathing?
No. So that's my story. And I did see that the conference that you all did in the CanMed conference, and the woman who had the hyperemesis, she really went through some trial and error with that, didn't she?
Yeah, she recently was interviewed in Forbes magazine, and you can find the article online. And, she details her story of, trying, I think she reported that when she used CBD, her symptoms were the worst, actually, which I thought was really interesting. But, and she talks a lot of just about how the industry has really treated her in terms of her attempts to, bring awareness to this issue and how hostile they've been towards her. And just, it's so interesting to see, what's considered this peace, love, one love community, how they can turn on you.
Yeah.
But yeah, I hope that if ACNA is able to have a conference in December as planned, I think we will have this topic there, and I probably would invite Alice Moon to be a panelist, because I think she's she's really become sort of a self-proposed expert in it, and has firsthand experience.
Yeah.
Yep. Mm-hmm. Fascinating stuff, huh?
Yeah. Meanwhile,
so you said, sorry.
No, go ahead.
Eloise, you said that the woman was saying that she had the worst symptoms when she was using CBD after already having kind of realized that that's what was going on.
Yeah, so she was, you know, she promoted herself as being a chronic heavy THC user and, you know, really enjoyed THC. And when she developed these symptoms, she thought, okay, well, I'll try CBD instead. And she said that she was sick for weeks after that.
Wow, that kind of points towards no on the CB1 factor, right?
Well, yeah, or how much THC is it that's causing this, right?
Definitely. So many variables.
Right. You know, or does CBD tend to have higher levels of these minerals than a THC variety? I mean, I don't know.
I think it does lend credence to this idea that there's likely not one single contributing factor. You know, when we talk about onset of CHS, I think, you know, if you had to point to one single thing that's causing it, I think that it's probably chronic and long-term use of THC. And then once people have it and they're trying to get off it, or they come back onto cannabis and use other cannabinoids, and you see a resurgence of it, that's when we can start to point, you know, at first. So then we have dysregulation at CB1, and then when they're using these other cannabinoids afterwards, and you see a resurgence of the disease, that seems to point to TRPV1. And maybe there's something else also that's happening that we just don't know it yet, because you know, again, there's such little research that's happening around this topic because it's so new.
I'd be really interested to hear if anybody is thinking about it being related to endocannabinoids and just their prevalence in the system. And
yeah, endocannabinoids, or you know, we talked a little bit about genetic polymorphisms and the way, you know, people don't, perhaps they have an enzyme that's causing too much of a THC metabolite, and it's causing THC to start to build up in the system to get to, you know, levels where you are always severely, your endocannabinoid system is always severely and chronically challenged. It's too low. Or maybe there's something happening with FA. There's too much FA in the system, and you have no, you know, there's no anandamide. Who knows? Really, and again, it's, you know, all of the medical literature is just really based around case studies right now.
Okay.
Interesting topic. I'll be glad to hear it from the beginning because I was a little late.
Yeah, we'll
That's
post
okay.
it. Yeah, we'll post it shortly, and I'm sure many of us have a little extra time these days to review. So I hope you enjoy it.
Oh yes, I enjoy all of yours.
Oh, good. I'm glad you were able to join us, even if it was for a little bit, Ruth. Well, I hope you guys stay healthy and well and sane during these crazy times. And Tim, have we decided what our next topic is?
We have not yet, so we'll discuss internally and come up with something fun. If you guys in the community have not sent a request for our private Facebook group, it's Radicle Community. So you can just search for it and then click the join button, and that'll send us a request, and we'll make sure that you get at it. But we've got a kind of a private Facebook group that we've got lots of conversations going there, a lot of good information coming out there as well. So so send a join request.
That guy that wrote that book about what you should be telling your children about cannabis, he was on TV last night, of course, doing all this propaganda about how terrible cannabis is and people don't know any better. So I don't know, it might be a good idea to do something on him again in the future.
God, he's coming back into the picture.
It's just terrible.
We were hoping if we just ignored him, he would go away.
No, Laura Ingram is giving him a platform, and she says she wants him back again, and I just cringe when I hear that.
Yeah, no kidding. Oh, God. All right, you guys. Well, have a great rest of your day, and we'll be in touch
You
about
too.
what we do next. Okay.
Okay, thanks a lot.
See you. Bye-bye, guys.
Bye.
Love,
Thank you.
Eloise, love the sweater.
Thank you. Nice to see you, Tess. I'll email you.
Yes, oh, good. Yes, please do.
I will.